This video will cover the basic and clinical pharmacology of the antidepressant drugs. These include the primary antidepressant drug classes of SSRI, SNRI, TCA, MAOIs, as well as miscellaneous agents. First, I will talk about the selective serotonin reuptake inhibitors, or SSRIs, which in general are the mainstay of depression drug therapy. The SSRIs are a class of drugs that inhibit the serotonin reuptake transporter, or SERT, which leads to increased serotonin in the synapse. The drugs in the SSRI class typically have very weak activity on norepinephrine and dopamine reuptake. As I stated previously, the mechanism of action of the SSRIs is to inhibit SERT, which will increase serotonin in the synapse. The primary SSRIs available for the treatment of depression are fluoxetine or Prozac, sertraline or Zoloft, paroxetine or Paxil, citalopram or Celexa, and escitalopram or Lexapro. Another drug in the SSRI class that is not listed here is fluvoxamine, because even though it shows great similarity to the SSRI drug class, fluvoxamine is indicated in the treatment of obsessive compulsive disorder, or OCD, and not for depression therapy. As a class, the SSRIs have very similar side effects. So the class adverse effects are listed in the second row of the table. These class adverse effects are due to the on-target effect of increasing serotonin signaling. This increased serotonin signaling contributes to decreased libido or other forms of sexual dysfunction, the possibility of developing serotonin syndrome, or sleep disruptions. And these can actually be either increased sleep or insomnia, depending on whether or not the particular drug is sedating or activating. In general, SSRIs have very similar warnings and precautions. So again, the class warnings are listed in the third line in the table. Again, these include things like QT prolongation. Most of the drugs in the SSRI class do prolong the QT interval, and additive QT prolongation can be problematic. These drugs are also able to produce SIADH, or the syndrome of inappropriate antidiuretic hormone. This can lead to a hyponatremia, a decrease in serum sodium levels that can be problematic. SSRIs are also included on the Beers list because of their increased risk of falls they produce, especially the more sedating SSRIs like paroxetine. And finally, when used in combination with NSAIDs, anticoagulants, or antiplatelet agents, they can increase the risk of bleeding. There are some unique features of each of these drugs that I will go through now. For fluoxetine, or Prozac, the most important thing to note is that it has a very long half-life, on the order of 2 to 3 days, compared to all other SSRIs have a half-life of approximately 1 day or less. In addition, the primary fluoxetine metabolite is also active. This is called norfluoxetine, and it has a half-life of 180 hours. Therefore, because of this long half-life and the fact that there is an active metabolite with an even longer or extended half-life, fluoxetine takes longer to wash out of the system after drug discontinuation. But upon discontinuation, there is also a self-taper associated with fluoxetine. And this means that there does not have to be a stepped down taper because of that long half-life, and fluoxetine has a much lower risk of a withdrawal syndrome upon discontinuation. Fluoxetine also inhibits the cytochrome P450 CYP2D6, and this may be problematic in polypharmacy. In general, fluoxetine is activating. It's structurally similar to many of the amphetamines, and this is what causes it to be CNS activating. Therefore, it should be taken in the morning and definitely not taken at night because of the CNS stimulation. Sertraline or Zoloft out of all the SSRIs is the one that is preferred if there are cardiovascular issues or a QT risk because it has the least likelihood of prolonging the QT interval. It does, however, have the lowest bioavailability of any of the SSRIs at about 45% compared to the others at 70% or greater. Paroxetine is also a CYP2D6 inhibitor, and therefore, in the case of polypharmacy, drug interactions should be evaluated. Paroxetine has the shortest half-life and therefore has the highest risk of withdrawal syndrome or drug discontinuation syndrome upon cessation, and paroxetine would definitely need to be tapered. Paroxetine in general is sedating, and so it should not be taken early in the day and is more likely to be taken daily at night prior to sleep because of the sedating effect. Citalopram is a racemic mixture, whereas S-citalopram is the S enantiomer only of citalopram. Both citalopram and S-citalopram are QT prolonging at higher doses, and therefore concomitant administration with another drug that prolongs the QT interval should be avoided. The next antidepressant drug class in terms of pharmacology are the serotonin-norepinephrine reuptake inhibitors, or SNRIs. The SNRIs inhibit SERT and NET, leading to increases in both serotonin and norepinephrine in the synapse. This slight difference compared with the SSRIs explains in some ways the different indications for this group of drugs, as many of them are also indicated for anxiety disorders, as well as their modified side effect profile given their actions on both serotonin and norepinephrine. When comparing the pharmacokinetics of the SSRIs to those of the SNRIs, in general, the SSRIs are higher oral bioavailability, whereas the SNRIs typically have lower oral bioavailability, whereas the SNRIs have shorter half-lives on the order of 6 to 12 hours compared to the SSRIs, which are closer to 12 to 24 hours. However, in general, most agents are taken daily. Some of them come as extended release formulations so that they can just be taken once daily, despite their shorter half-lives in the SNRI class. The primary SNRIs I will mention are venlafaxine or Effexor XR, desvenlafaxine or Pristiq, duloxetine or Cymbalta, and levomenacepran or Fetzima. Again, these are all serotonin-norepinephrine reuptake inhibitors that block SERT and NET to increase both serotonin and norepinephrine in the synapse. This leads to their class-specific adverse effects, both serotonergic and noradrenergic inactivity. So the serotonergic side effects include things like the decreased libido and sexual dysfunction, as well as serotonin syndrome, whereas the noradrenergic side effects include hypertension, tachycardia, and sweating. Like the SSRIs, these drugs also can produce SIADH, which may result in hyponatremia. They are also included on the Beers list due to their ability to increase the risk of falls, and that is again due to some of the sedating nature of these agents, as well as their ability to increase bleeding when administered concomitantly with an anticoagulant, NSAID, or an antiplatelet agent. For venlafaxine, or Effexor, some of the unique features of this drug compared to the other SNRIs is that it has the highest risk of the withdrawal or drug discontinuation syndrome, and therefore venlafaxine must be tapered appropriately. Out of all the SNRIs, which in general have a decreased risk of QT prolongation, venlafaxine is the one SNRI that does potentially still prolong the QT interval, and therefore additive QT effects should be reviewed. Venlafaxine also is indicated in the treatment of generalized anxiety disorder, social anxiety disorder, and panic disorder, in addition to being indicated for depression. Desvenlafaxine is very similar to venlafaxine. It's simply the demethylated metabolite of venlafaxine. It's metabolized by CYP2D6 from the active venlafaxine to the also active desvenlafaxine, but the drugs can be administered either in the prodrug or the active metabolite form. Duloxetine or Cymbalta has some effects against neuropathic pain and therefore could be considered in situations where there is both depression and neuropathy. Hepatic impairment does significantly affect blood levels of duloxetine, and in cases of hepatic impairment, toxic levels of duloxetine can build up, and therefore the dose must be modified in individuals with hepatic dysfunction. And finally, levominosopran, or Fetzima, is the active enantiomer of another drug called milnacipran, or Savella. Milnacipran is approved for depression, but not in the US. And levominosopran is the L-rotary active enantiomer of this agent and is approved in the US for the treatment of depression. The next pharmacologic class of antidepressants are the tricyclic antidepressants, or TCAs. These agents have a very similar mechanism to the SNRIs in that they inhibit both SERT and NET to increase serotonin and norepinephrine in the synapse. Many of these drugs also have structural similarities to the muscarinic antagonists and to the histamine antagonists, which contributes to their wide variety of side effects. Given this variety of side effects and the fact that the SNRIs have a similar mechanism of action with fewer muscarinic and histaminic side effects, use of the tricyclic antidepressants has in many cases been replaced by some of the newer classes like SSRIs and SNRIs. However, the TCAs can be very effective in situations where the individuals do not respond to some of the more common therapies, or if they've responded fairly well to a tricyclic antidepressant in the past, like amitriptyline, which in general is used very commonly and is well tolerated despite the many side effects it can produce. The tricyclic antidepressants, as the name implies, have a tricyclic structure. These can be further subdivided into chemical classes of tertiary amines and secondary amines. The primary tertiary amines include amitriptyline and doxepin, as well as clomipramine and imipramine. The primary secondary amine TCA is nortriptyline, and some other secondary amine TCAs include desipramine and protriptyline. As I mentioned previously, these drugs inhibit SERT and NET to increase synaptic serotonin and norepinephrine, and their structural similarity to muscarinic and histaminic antagonists leads to their many side effects. These class side effects include orthostatic hypotension, which is a result of their alpha-adrenergic antagonist activity, anticholinergic effects, which is a result of inhibiting muscarinic cholinergic receptors. And these are things like dry mouth, blurry vision, urinary retention, and constipation. These agents also produce weight gain and sedation, which are due to their activity at the histamine receptor. The class warnings for the TCAs include a risk of QT prolongation, as well as a fall risk as defined on the Beers list. All the agents in this class have a class pharmacokinetic activity of being metabolized by CYP2D6 to inactive metabolites. And this can be potentially of concern in someone who is a CYP2D6 poor metabolizer, because that may reduce metabolism of these agents, leading to toxicity. As I mentioned, amitriptyline and doxepin are both tertiary amines. These agents both have more balanced activity between norepinephrine and serotonin, meaning they inhibit SERT and NET fairly equally. This typically produces higher efficacy, but the tertiary amines also tend to have more side effects than the secondary amines. Doxepin, interestingly, is also often used off-label as a hypnotic or as an antihistamine to reduce itching or pruritus. The tertiary amine TCAs are much more likely to cause sedation and weight gain, as well as anticholinergic side effects because of their higher activity at those receptors than the secondary amines. The primary secondary amine is nortriptyline. This is slightly more selective for norepinephrine over serotonin and also slightly less anticholinergic than the tertiary amines. In cases where the anticholinergic side effects are not well tolerated, the secondary amine nortriptyline may be a better option. Next, we will move into discussing some of the miscellaneous agents that have what I called earlier a weird mechanism of action. And the first drug we'll talk about is bupropion, or Wellbutrin. Bupropion inhibits both dopamine and norepinephrine reuptake by inhibiting the DAT and NET transporters, which increases dopamine and norepinephrine in the synapse. Bupropion does increase the risk of seizure and therefore should be avoided in individuals who have a seizure disorder or at higher risk of seizures for another underlying reason. The primary adverse effects of bupropion are that it is activating and therefore should be taken in the morning and not at night because of the CNS stimulating effect. It also can cause some dry mouth as well as some weight loss, which may actually be of benefit in certain situations. It also has a lower risk of sexual dysfunction than some of the other drug classes like SSRIs and SNRIs. There are some other uses for bupropion outside of depression therapy, and this includes for smoking cessation, where its previous trade name was Zyban, or in a combination with naltrexone for weight management, which is called Contrave. The next miscellaneous agent is mirtazapine. Mirtazapine has a very different mechanism of action than most antidepressants. It is actually an alpha 2 adrenergic antagonist. And when mirtazapine acts centrally to inhibit the presynaptic alpha 2 adrenergic receptor, this actually results in an increase in norepinephrine and serotonin in the synapse because the feedback mechanism of reduced release is being inhibited. Mirtazapine also has activity at the serotonin 2 and 3 receptors as an antagonist, as well as a histamine H1 antagonist. And for that reason, it's very sedating and should be taken at night rather than early in the day. Mirtazapine does have a lower risk of sexual dysfunction compared to other antidepressants, but does carry a risk of additive QT prolongation. Mirtazapine is frequently used in oncology and nursing settings to induce sleep because it is so sedating and to stimulate weight gain because as an H1 antagonist, it can cause weight gain. The next two miscellaneous antidepressants are vortioxetine and vilazodone. Both of these drugs act as SSRIs with some additional activity at serotonin receptors. Vortioxetine is an SSRI, a 5-HT1A agonist, and a 5-HT3 antagonist. The 5-HT1A agonism leads to direct activation of serotonin activity, and the 5-HT3 antagonist activity is actually antiemetic. Vilazodone is both an SSRI and a 5-HT1A partial agonist. These agents can increase the risk of seizure and should be avoided if someone has a seizure history or an increased risk of seizure. The primary adverse effects of these agents are very similar and include nausea, vomiting, and diarrhea, or GI side effects, insomnia, as they are somewhat stimulating, and these agents do have fewer sexual side effects than the SSRIs and SNRIs. The next two agents are trazodone and nefazodone. Trazodone inhibits SERT, so it functions like an SSRI, but it also blocks 5-HT2A, histamine H1, and alpha 1 adrenergic receptors. The 5-HT2A blockade leads to increased release of norepinephrine and serotonin because it turns off the negative feedback mechanisms, whereas the H1 and alpha 1 adrenergic antagonist activity lead to the side effects of trazodone. Trazodone does carry a risk of additive QT prolongation, and given the histaminic effects, is relatively sedating and should be taken at night rather than early in the day. Trazodone is very commonly used as a non-habit forming hypnotic for insomnia, although this is an off-label use. Nifazodone has very similar activity. It does inhibit both SERT and NET, as well as blocking 5-HT2A and alpha-1 adrenergic receptors. It does carry a black box warning for hepatotoxicity, and it is less sedating than trazodone because it lacks the histamine H1 antagonist activity. One unique feature of nifazodone is that it has only 20% oral bioavailability, which is one of the lowest of any of the antidepressants. In general, the added 5-HT2A antagonist activity of these two agents results in a combination anxiolytic, antipsychotic, and antidepressant effect. And this is most clearly demonstrated by actually agonists of 5-HT2A, like LSD, which are both anxiety producing or anxiogenic and hallucinogenic. So when you block this receptor, you get reduced anxiety, decreased psychotic features, and reduction in depression symptoms. The last miscellaneous agent I will mention is brexanolone. Brexanolone is a synthetic form of the progesterone-like hormone allopregnanolone. And it's known that decreases in allopregnanolone can lead to a decreased release of BDNF and decreased neurogenesis. Thereby replacing allopregnanolone leads to increased neurogenesis and has an antidepressant effect. It is a Schedule IV controlled substance and can be sedating, so that is something to consider. It is FDA approved for postpartum depression, in which setting it is administered over a 60-hour continuous IV infusion, typically shortly following labor and delivery in cases of postpartum depression. The last pharmacologic class of antidepressants we will talk about are the monoamine oxidase inhibitors, or MAOIs. These are the drugs that have been around the longest in terms of antidepressant drug therapy, but they also are associated with the most side effects and drug interactions. And therefore their use has largely been replaced with the SSRI and SNRI drugs. The MAOIs tend to be reserved for patients who do not respond to any of the other available treatment options. The monoamine oxidase inhibitors non-selectively inhibit the monoamine oxidase enzyme. This is the enzyme that's responsible for metabolizing norepinephrine, dopamine, and serotonin, as well as epinephrine. And by blocking this metabolism, there are increased levels of the monoamine neurotransmitters, epi, norepi, dopamine, and serotonin in the body. The primary monoamine oxidase inhibitors are isocarboxazid, phenelzine, and tranylcypromine. Again, these are non-selective inhibitors of the monoamine oxidase enzyme. And by that, I mean they generally non-selectively inhibit both the MAO-A isoform and the MAO-B isoform. Together, these two isoforms of monoamine oxidase are responsible for metabolizing the monoamines epi, norepi, dopamine, and serotonin, and therefore inhibition of the metabolic activity of this enzyme results in increased levels of those monoamine neurotransmitters. However, there are many class adverse effects associated with these drugs. Because of the increase in serotonin signaling, they do have the risk of serotonin syndrome, especially when administered with other serotonergic drugs like SSRIs, SNRIs, and TCAs. Serotonin syndrome is characterized by nausea, vomiting, diarrhea, dizziness, headache, agitation, tachycardia, and hallucinations. Because of these drug interactions for serotonin syndrome, there is at least a 2-week washout period required for transitioning from an MAOI to an SSRI, SNRI, TCA, or bupropion, or vice versa. The only exception to this is for fluoxetine, which, because of its much longer half-life than other antidepressants, requires at least a 5-week washout period. Because MAO also metabolizes epinephrine and norepinephrine, the increased levels of these neurotransmitters can result in hypertensive crisis. So one of the class side effects is hypertension, and if MAOIs are administered either with drugs that increase epinephrine levels like phenylephrine, etc., or when given with tyramine-rich foods, which increase norepinephrine, and these include things like red meat, red wine, and unpasteurized and unprocessed cheeses, that can lead to the potential for a hypertensive crisis. And so drugs that increase epi or tyramine-rich foods should be avoided. The structure of the MAOIs does resemble amphetamine, and therefore these drugs also tend to be CNS stimulating and are more likely to be taken in the morning for that reason. These drugs are subject to extensive first pass metabolism, and because they also inhibit monoamine oxidase in the gut, this can lead to a pressor effect or a hypertensive effect on first administration. Again, because of the wide variety of side effects and drug interactions associated with the MAOIs, these are reserved for patients who do not respond to other treatments. Finally, in treatment-resistant depression, there are some other agents or options available for patients. By definition, treatment-resistant depression is depression that does not fully respond to at least 2 full therapeutic trials of drugs. A full therapeutic trial is considered 4 to 8 weeks at a therapeutic dose. If there's no response or an incomplete response to 2 full trials, the options include switching to a new drug or trying a third drug essentially, increasing the dose of the current agent, adding a second antidepressant drug that has a different mechanism of action, or to augment the current antidepressant with one of the following augmentation options. So some common augmentation options include the anxiolytic drug buspirone, the NMDA antagonist esketamine, the mood stabilizer lithium, thyroid hormone if low thyroid is an underlying cause, or electroconvulsive therapy. All are considered augmentation agents. In addition to the atypical antipsychotics. The primary atypical antipsychotics that would be used in treatment-resistant depression are aripiprazole, olanzapine, which is found in combination with fluoxetine called Symbyax, quetiapine, and brexpiprazole. Aripiprazole or Abilify is a dopamine serotonin partial agonist. Olanzapine, as an atypical antipsychotic, is a dopamine receptor, serotonin receptor antagonist. Quetiapine, also an atypical antipsychotic, has the dual dopamine serotonin receptor antagonist activity. And brexpiprazole, or Rexulti, which is very similar in mechanism to aripiprazole, is also a dopamine serotonin partial agonist. Esketamine is an NMDA antagonist that decreases glutamate signaling. It actually has a rapid onset of antidepressant activity when administered as a nasal spray. It can produce antidepressant effects within minutes to hours, but patients do need to administer the esketamine nasal spray under supervision and be monitored for the following 2 hours for any psychosis-like effects or other side effects. We will talk about buspirone, the anxiolytic, and the atypical antipsychotics in much greater detail in some of the upcoming units. So for now, I simply wanted to mention that these agents are available for the augmentation of treatment-resistant depression and to provide to you their mechanisms of action. This graphic does a nice job of summarizing the activity of all the antidepressant drugs that we just talked about. The drugs are indicated by class. So for example, the blue are TCAs, the red are SSRIs, the purple are SNRIs, etc. And the circles along the same row as the antidepressant agent indicate what activity those agents have. So for example, bupropion, as we talked about previously, it's considered a norepinephrine dopamine reuptake inhibitor, or NDRI sometimes it's called. And you can see here it blocks norepinephrine or noradrenaline reuptake as well as dopamine reuptake. If you choose a TCA like amitriptyline, you can see that it blocks both serotonin and norepinephrine reuptake, as well as has activity on several postsynaptic receptors, including serotonin 5-HT2A, alpha adrenergic, histamine, and muscarinic receptors, and that is what causes the side effects of amitriptyline. This is a really nice activity summary to refer to when you're trying to recall the mechanism of action and activity of all of the various antidepressant drugs. This figure is similar, but it shows the activity of antidepressant drugs in more of a map or an outline format, where you can see drugs like the SSRIs, fluoxetine, sertraline, etc., inhibit primarily serotonin reuptake by blocking SERT, or something else like phenelzine, which is a monoamine oxidase inhibitor, you can see inhibits the monoamine oxidase enzyme. If you tend to be more of a diagrammatic or spatial learner, this map might be a bit more helpful than the table on the previous slide in terms of reviewing the activities and the off-target side effects of all of the various antidepressant drugs. Now is a good time to review all of the antidepressant drugs and the drug classes that we've talked about by completing the optional review assignment in Canvas. Taking a pic of the QR code on the screen will bring you directly to the review assignment, which will ask you to create a table or diagram outlining all of the antidepressant agents we've covered.